Dear students, welcome to E-Pathshala. I am Professor Sandhya from the School of Economics, University of Hyderabad. Today the module I am going to speak on is on health insurance. The learning objective is to describe the need for health insurance, theoretical basis for health insurance, reasons for market failure in health insurance, and some research studies that were done on health insurance. To begin with, one should know what is health insurance. Health insurance is defined as a health financing mechanism that involves distribution of financial risk associated with the variation of individuals' healthcare expenditures by pooling costs over time, prepayment, and over people. Health insurance serves as a means to protect households from the risk of medical expenses that can be large relative to their modest incomes. Health insurance is a risk-sharing mechanism that lowers the out-of-pocket expenditure price for medical care at the time of purchase by smoothing medical payment across individuals and time, according to Barr 1992. Studies conducted in low-income countries have found that households with access to insurance can diversify their financial risk and potentially raise income levels, Townsend in 1995. This suggests that excluding the poor from health insurance may contribute to inequality in access to care and negatively affect health status. These are important health policy concerns in many countries. Wagstaff et al. In 2001 observed this. Decisions under uncertainty. As all of us have noticed in the earlier module that healthcare decisions are taken. There are three uncertainties involved in the healthcare market. So, how to deal with the decisions under uncertainty? One of the characteristics of health is uncertainty. Uncertainty is there in three forms: relationship between healthcare and health services. About contacting the disease, uncertainty is there about financial burden on the patients. Generally, insurance demand studies use expected utility theory to explain individuals' decisions of whether or not to insure. Under this theory, the demand for insurance reflects individuals' risk aversion and demand for income certainty. Shoemaker in 1982. Because of asymmetric information between patients and physicians, many of the choices made by healthcare consumers as well as providers involve a substantial amount of uncertainty. For a patient, the timing of illness and medical expenditures are uncertain. From the healthcare provider's perspective, patient load and types of treatment are unknown before they actually occur. Since they are unpredictable, there is a substantial degree of risk. Most people generally dislike risk. They are willing to pay some amount of money to avoid it. This is where the health insurers enter the market as a third-party provider. As a result of this inability to plan when a future event will occur, an unregulated market would respond by developing insurance mechanisms whereby an individual pay premiums to a risk pooling agency which will make financial reimbursement in the event of illness. Under expected utility hypothesis, insurance demand is a choice between an uncertain loss that occurs with a probability when uninsured and a certain loss like paying a premium, that is according to Manning and Marquez in 1996. Expected utility theory assumes that people are risk averse and make choices between taking a risk that has different implications on wealth. At a time of insurance choice, consumers are uncertain whether they will be ill or not and of the related financial consequences. Insurance reduces this uncertainty. Through insurance, they can level out their income over two different states, ill or not ill, which makes the aggregate outcome relatively certain. This certainty allows the insured to reach higher utility in case of illness than those without insurance. Accordingly, the insurance demand reflects individuals' risk aversion and demand for certainty, implying that the more risk averse individuals are, the more insurance coverage they will buy. Begg et al. In 2000 Risk aversion and risk preference. Figure 1 shows the relationship between utility and wealth. An individual with a positive marginal utility of wealth is faced with a choice between a certain amount of wealth, say rupees 1000, and a 50-50% chance of rupees 800 or 1200. The actual amount is being determined by the toss of a fair coin. Since half of 800 plus half of 1200 is equal to 1000, the expected outcome matches the certain amount. It is described as a fair bet. Risk averters reject a single fair bet because of their preferences for certainty, whereas risk preferred people accept one. Assume that we know utility associated with the sums of 800 and 1200, and we can plot them as points f and g explained in the figure. The expected utility associated with the bet is found to be as 1000 rupees, and the utility associated with the expected outcome is E, which is in between F and G points. If an individual accepts the bet of either 800 or 1200, then the utility of 1000 is at point T below E, which is a risk preferer. If the individual rejects the bet, then U of 1000 is above E at point R, joining F or G and FTG. An increasing marginal utility of wealth, increasing slope of utility function, risk preferer FDG, decreasing marginal utility of W, decreasing slope of utility function. Risk averter FRG, who are the individuals who insure against healthcare expenses. Okay. Here we must know the concept of actuarially unfair premium. For example, in a community of 10 people, each person has 1 in 10 chance of incurring healthcare expenditure of rupees 1000 per annum. Each would take an insurance policy by paying rupees 100 per annum if it were actuarially fair. If administrative costs are rupees 100 per annum, each person will be willing to pay the actuarially unfair premium of rupees 110. People are more likely to insure against larger losses which are unpredictable from against smaller losses which occur more regularly and more predictable. Example, visit to a dentist for a checkup every 6 months will not be insured. Reasons for market failure in health insurance. There are 3 reasons for the market to fail in health insurance. 1 is adverse selection, 2 moral hazard, 3 economies of scale. Adverse selection. Adverse selection results from asymmetry of information in the insurance market. That is, buyers of insurance tend to have more of an idea of their risk status than sellers of healthcare insurance. In a competitive market, insurance companies set the premium keeping into account the general health risks of the insured population, that is average risk level of population. That is what is called as community rating. For some population who perceive their own risk level is lower than the average, the community rating will be too high. They will decide not to insure, which results in an increasing the average risk of those remaining insured. To cover the projected health costs of this population, premiums will again rise. As a result of this, once again some people will drop out of insurance coverage who perceive their risk status to be lower than the average of those remaining insured. This process whereby the best risks are gone out of the insured group is called adverse selection. The insurance company should tailor premiums to levels of risks of individuals rather than the population, which is called experience rating. The process by which low risk individuals are drawn into low premium plans is called skimming off or creaming off. Premiums will reflect assumed future risk levels based on some idea about past history of personal and family health. High risk groups, lower paid elderly people and chronically sick will have to pay higher experience rated premiums to maintain coverage which they cannot afford now. Thus, they will be out of insurance plans. 2 groups may be left out because of adverse selection, those of low risk and those of high risk who cannot afford experience rated premiums. Adverse selection constitutes market failure for the former group but not for the later. For the former group, the transaction via markets is prevented by asymmetry of information about risk status. Because of asymmetry of information, low premium insurance policies are not offered because of the fear that some high risk people might take up such policies. For high risk groups, the market does not fail, but their financial resources cannot cover the costs of insurance. The market has not failed in its transfer of information between supply and demand of healthcare insurance. Whether this social problem is defined as market failure depends on externality. How much members of society care about the exclusion of others from access to needed healthcare, it depends on externality. There are two types of externalities here. One is selfish externality and two is caring externality. Selfish externality. Benefits may arise that others are vaccinated, which has direct effects on the risks to one's own health. Caring externalities. Benefits may also arise from knowing that someone is receiving needed health care which does not affect one's own health. An unregulated market do not account for individuals' willingness to pay for external benefits. Such market lead to unproduction of health care. Once this willingness to pay or demand is added to that generated by private individuals accounting for only their own costs and benefits, that more healthcare would be demanded. Figure 2 gives the relationship between the marginal value of an individual and marginal social value to the society. In figure, MVA represents poor individuals' demand curve for healthcare, that is the value placed on additional amounts of care as represented by individual A's willingness to pay for them at price PE for healthcare. The amount of healthcare allocated to A would be QE. Individual B, a rich person, also gets some value from A's receipt of healthcare and B would be willing to pay for this as represented by MVAB, that is the marginal value to B of A's consumption of healthcare. Adding these two marginal value curves together results in the curve representing the total marginal value of A's consumption of healthcare, that is MSVA, the marginal social value of A's consumption at price PE. Provision of care to A after accounting for externalities would be Q1. The market was previously underallocating resources to healthcare, in this case by an amount of OQ1 minus OQE per annum. How to transfer from individual B to individual A to allow A to purchase his or her required healthcare? The most efficient way of achieving is through purchase of insurance or taxation. The government bears the administrative costs of the transfer. Diseases and services exclusion also takes place, and additional diseases used by insurer to insulate themselves from the impact of diseases and services which would generate high costs for them. These include psychiatric disorders, which often is explicitly excluded in the US form from the costs of service benefits covered by health insurance contracts. Community rating. Everyone in the covered population of the insurer pays the same premium irrespective of age, income and their own other personal characteristics. Example, rating means that insurer varies the premium charged according to the usual experience of the individual covered of the whole group in relation to other population groups. Adverse selection, where the insurer refuses insurance coverage to the groups of high risk individuals such as example AIDS patients and others with chronic expensive conditions. Countering adverse selection. There are 4 ways of countering adverse selection. 1. Providing free healthcare. 2. Making healthcare insurance compulsory. 3. Experienced rated premiums with subsidies. 4. Selective community rating. Effect of insurance on the demand for health services. In insurance-based healthcare system, the problem of potential excess demand exists because of moral hazard. Excess demand results in the benefits foregone from resources used in healthcare provision being exceeded by the benefits, that is opportunity costs, from the use of these resources in alternatives which is currently funded. The levels of demand and the provision will be greater with insurance than in a perfect market with fully informed consumers. This is due to moral hazards. Moral hazard is basically a change in the attitude of consumers and producers which result because of insurance against the full cost of such care. There are two types of moral hazards: consumer moral hazards and provider moral hazards. Consumer moral hazards, it arises because of the fact that insurance reduces the cost, that is the financial cost of treatment at the time of consumption, and hence makes being ill less undecided state. Thus, the incentive to adopt a healthier lifestyle is diminished and the probability of requiring care rises. 2. A zero reduced price at the point of use encourages a high rate of use than would otherwise be consumption efficient. Moral hazard and insurance. Figure will explain the relationship between moral hazard and insurance that will increase the demand for health. Figure 3 explains the relationship between moral hazard, which is due to insurance, and because of the moral hazard, there is an increase in the quantity demanded by the people who are insured. The characterization of moral hazard is very neoclassical. The above demand curve in figure 3 is that of fully informed or rational consumer. A zero price of healthcare at the point of delivery would result in overconsumption of healthcare relative to what would occur under normal market mechanisms. Example, an individual faces a half chance of keeping well and not requiring healthcare, and half chance of being ill and requiring 100 units of healthcare. Assuming healthcare is supplied along a perfect elastic supply curve at price ₹5 per unit. The fair insurance premium equals to half of 5 and half of 100 into 5. The fair insurance premium equals to half of 5 plus half of 100 into 5, that is 250. DA is the demand for healthy care when the individual is well, which is inelastic and coincides with y-axis. The individual A is well. D-A, that is the demand curve when the individual becomes ill, being perfectly inelastic at 100 units of healthcare. The moral hazard probably arises once the demand curve for healthcare exhibits a degree of elasticity, as with the demand curve D-A'. Now, once the illness strikes, the individual demands 150 units of healthcare. Fair premium equal to half of 0 into 5 plus half of 150 into 5, which becomes 375. The individual may not choose to accept insurance at the fair premium. Each individual comes to know that the existence of moral hazard increases the price of his own premium. This gives rise to inefficiency. His decision depends on efficiency loss that arises on the last 50 units of care consumed more or less than the utility gain that arises from being insured. The amount that an individual would have to pay for service V of insurance if services charges exceeded KLM or ₹125, that is 15 to 2.5, there is a welfare loss. People will not insure. The risk covers people that take account moral hazard may reject health insurance. There are few mechanisms to counter the consumer moral hazard. One is deductibles. If ill, an individual has to pay for the first specific number of visits at the market price and the remainder being free. Example, 125 is the deductible because the efficiency or consumer surplus loss incurred because the units paid between 100 and 125 at the market price exceed their marginal value to the extent of KEF is balanced by the surplus gain accrued to the future units of healthcare between 125 and 150. That is FGM. For a deductible below 125, the individual will accept the insurance policy and he rejects one above 125. 2. Use of co-payments. The insured person pays some fraction or absolute amount of supplier's charges. In the figure, for co-payment of 50% of 2.5 has to be paid by the individual, reducing the quantity of healthcare demand to 125 units. Fixed periodic per capita payment by consumer directly to the provider of comprehensive healthcare such as health maintenance organizations. HMOs are non-profit organizations which combine the supply of healthcare with insurance. They are prepaid group practices where subscribers pay a capitation fee and receive family compensation healthcare at zero or low priced. Fourth mechanism to counter moral hazard is provision of incentive for consumers to demand care from selected providers offering low cost package of care, as in the case of PPO, preferred provider organizations. The fifth one is fixed indemnity, placing financial limits to indemnity, fixing financial limits on the amount that will be provided by the employer or insurance companies. In India, they are ESI and CGHS. The above 1 to 4 are practiced in private insurance as in USA. The sixth mechanism for countering the moral hazard is non-pricing, rationing by doctors according to judgments of need, usually resulting in consumers incurring waiting costs for selective treatment. The fifth one is public insurance as practiced in UK. Provider moral hazards. It can result from a simple lack of awareness of costs or from the use of fee for service remuneration methods for doctors, in which fees departs from the market prices. In systems that use fee for service methods of remuneration, doctors are paid a fee for items of service provided to patients. In such system, doctors have a financial incentive to provide care in excess of what have been with informed customer, that is supplier induced demand. Countering provider moral hazards, there are 4 methods to counter them. 1. Financial limitations imported at a global level by clinical or institutional budgets at a case level, prospective reimbursement for patients within diagnostic related groups, or by fixed periodic prepayments to hospital maintenance organizations, primary care doctors for provision of their own care or for purchase of hospital care on behalf of their patients. Example, in Canada this system is practiced. 2. Non-pecuniary incentives resulting from the pressure of peer review, financial reward for good practice. Third, use of salaried service in order to cap payments to provider of care. 4. Direct government's regulation as a means of controlling providers, such as limited list for drug prescriptions by general practitioners as practiced in Norway. Some examples taken from the studies conducted in health insurance. Devadasan et al. In 2010 evaluated CBHA schemes, the Accord AMS Ashwini scheme in Tamil Nadu state. By observing 545 households, they found that insured parents had hospital admission rates 2.2 times higher than the uninsured patients, so showing there is a moral hazard. Earlier, Devadasan et al. In 2007 assessed that among Accord insurance enrollees, 67% of households were protected from making out-of-pocket payments and 8% would have experienced catastrophic health expenditures in the absence of insurance scheme. Community-based health insurance in India with perhaps Yashaswini has yet to cover a large enough fraction of the population. Moreover, all the schemes provide only a limited benefit package. Other barriers to scale up of these schemes include low revenue generation, limited risk pooling, adverse selection and adequate management and organizational capacity, as observed by Precker et al. In 2004. A study by Shaktivel Shalvaraj and Anup Karan say that the impact of publicly financed health insurance schemes on financial risk protection in India's health sector, with special reference to the implications of various publicly financed health insurance schemes conducted in 74 districts from Andhra Pradesh, Karnataka and Tamil Nadu, the data collected from Consumer Expenditure Survey, which was conducted by NSSO. Households' real per capita out-of-pocket expenditure have increased significantly during the last 5 years when the survey was conducted, at an average annual growth of approximately 1.9%. The headcount in the catastrophic nature of hospitalization has increased marginally in the post-insurance years, both in intervention and non-intervention period. The catastrophic headcount across income expenditure quintiles, both in the past and post-insurance period, show a consistently higher number in the intervention districts to the non-intervention districts. The 4 public sector non-life insurance companies continue to contribute a major share of health insurance premium at 62%, while the private sector non-life insurance contribute only 26% of the gross health insurance premium. The remaining 12% has been contributed by the standalone health insurance companies. High claims ratios is a challenging issue for all providers. The third reason for market failure in health insurance market is economies of scale. A proportionate saving in cost gained by an increased level of production leads to economies of scale. So, the administrative costs of private insurance companies will be higher, which will be passed on to the insurers. That is why there is a market failure due to economies of scale. Thank you.